My name is John Plourde. I'm the owner of Advanced Neurodiagnostics. We're a neurodiagnostic company that comes to your practice, and primarily we perform nerve conductions and electromyography in office. We basically bring everything needed to your office to perform the studies. I come in with a medical assistant, which is a female. We bring the equipment, all the materials, supplies. Essentially all we need is a single exam room to perform the studies and to evaluate the patients. Generally we'll get a copy of the schedule the day before. We can call to confirm patients. The only thing your office needs to do is to get authorization for their procedures. When the patients sign in, my medical assistant will get the patients, perform the study. We do all the billing, we do the interpretation, and print out the reports that day, and the studies are left there that day. We come in once a week to as infrequently as once a month, depending on the amount of patients needed.
Tell us a little bit about your education and work experience.
My primarily my education is as a physician associate. I trained at Tribeca Nazarene in Nashville, Tennessee, and then I got a master's degree in clinical neurology at University of Nebraska School of Medicine in Omaha, Nebraska. Also did 2 years of electrophysiology training and neuroelectrophysiology training at the University of Florida Shands Hospital VA Medical Center in Gainesville, Florida. I've primarily worked in general neurology for about 15 years. I worked in neurointerventional medicine or pain management, performing EMG nerve conduction studies, but I also perform interventional pain procedures like epidural steroid injections, nerve block, cassette blocks. I perform needle-guided nerve blocks, also chemodenervation with Botox, needle-guided using the EMG equipment for treatment of spasticity and dystonias.
Can a physician assistant perform EMGs?
PAs can perform EMGs. PAs essentially perform any procedure that the supervising physician performs. There's really two ways of looking at it. One is the state board, which regulates the scope of practice. The requirements there is that the PA is performing procedures or treatments that's under the general supervision of the supervising physician, but also within their scope of practice. For example, if the supervising physician was a dermatologist, then no, the PA shouldn't be performing EMG nerve conduction studies. But as far as orthopedics or orthopedists, pain specialists, neurologists, any physician that basically is treating neuropathies, entrapment, pain, spinal disease, back pain, chronic pain syndromes, if the PA is trained in the procedures, and there has to be some evidence that they've had substantial training, supervising physician has seen them demonstrate the skill and feels that they're competent, then the Board of Medicine is okay with PAs performing that. In my case, there's overwhelming credentialing as far as electrophysiology, general neurology, in my experience. I did want to say one more thing. I trained for years under many general neurologists. Two of the neurologists I trained under were both back-to-back residents at the Cleveland Clinic. They trained under Hans Luters and Wilder, both premier electrophysiologists and neuroscientists. I've also trained under a neurologist from Harvard, Brigham's Women and Children's Hospital in Boston, Massachusetts. Trained under a neurologist from the University of Michigan in Ann Arbor. Essentially working with all these various neurologists over the years, I've really taken some of their pearls or their better techniques and kind of assembled my own way of performing the studies. When I come into your office to do the studies, I basically do a complete neurological evaluation, including a neurological exam, and then each of my studies is tailored towards that patient. Because I'm so well trained in clinical neurology, my exam really helps with being able to focus in on the problem right away, ruling out upper motor neuron disease or a primary demyelinating disease, other neurologic central suprasegmental insults that may be causing the problem, and coming to a differential, and then taking the EMG nerve conduction study and focusing on what I think is the problem, and even performing advanced nerve studies that I've learned over the years to accentuate any problem and to bring this out. My reports, basically, the style of reporting, I don't use a lot of electrical jargon, electrophysiology. It's a very clinical and practical report. Even if the study is negative or something that the primary or the referring physician referred the patient, let's say carpal tunnel, we didn't find carpal tunnel. In my report, I will basically address carpal tunnel. I will say that we were unable to demonstrate an entrapment neuropathy at risk consistent with carpal tunnel. We found a C6 or C7 radiculopathy. But this way, at least the referring physician knows that I got the information, I got the referral, I knew what he or she was looking for, and this was ruled out. I hate nothing worse than getting a report a month later when I've referred a patient to somebody and getting a report that doesn't make sense.
Some companies perform the NCV without the EMG. What's your opinion on that?
There's really no such thing as performing an NCV without EMG. It's one exam, it's one examination. It also goes along with the neurologic exam. What's happened over the years is some companies have started doing, mobile services where they'll send out technologists because EMGers are hard to come by. So they can send out technologists to do the NCV, and they use some wording and they make it sound good that the NCV can be done without an EMG, but it's really an incomplete test. The NCV is basically looking at the peripheral legs and arms for entrapment neuropathies, or it's looking for a generalized polyneuropathy, where the EMG is really looking at the radiculopathy, the nerve roots. So you need both. Even with the entrapment neuropathy, the needle exam is what will tell us whether the entrapment neuropathy is severe. It will grade the severity. There's axonal loss, whether there's active denervation, and that's important, especially for a surgeon that is treating carpal tunnel in a patient that may have had hand pain and weakness and numbness for 6 months. If the study comes back severe ongoing denervation with a severe entrapment neuropathy, that surgeon probably isn't going to consider splinting and cortisone injections. Surgery is probably the treatment at that point. There's no way of testing the nerve roots with an NCV. Some people have done this during surgery. They put an electrode on one side of the ganglia, the preganglia and the postganglia, and ran a electrical signal and recorded it. But that's really not practical for the average patient. The only ways of assessing those myotomes is going in there with a needle, various muscles, and looking for denervation. And that's how you come about diagnosing radiculopathy. Some will say F waves will help you, but really F waves we found in the last 10 years are really no use at all in radiculopathy. Sometimes they can help confirm radiculopathy, but even then they really don't change the grade of radiculopathy, the severity. It may just be additional information at best.
What about the patient who is fearful?
I did want to say one more thing. Also, when you have a technician that's performing these nerve studies, and then they send the study off to be read in another state by a neurologist, and the reports come back essentially looking just like that. it was read by somebody in 3 different area codes or zip codes over that really never saw the patient, has very little history. Also had a technologist just basically applying electrodes, and the reports that come back really are almost meaningless. It's just electrodiagnostic sort of jargon that when you get this report back, it doesn't give you any more information about the patient at all. When I do an exam, it's a complete neurologic exam. I'm tailoring the nerve studies. I even use deep needle recordings to evaluate for proximal neuropathies, suprascapular lesions, axillary lesions. These you have to go in and not only record from the surface, you actually have to record the nerve conduction with a needle, because the distances are so short, you get something called volume conduction. So it takes somebody that's highly trained to go in there and record these. But on the other hand, being able to diagnose a suprascapular lesion, especially in shoulder pain, we now think almost nearly 30% of patients with shoulder pain may have some form of suprascapular neuropathy. So it's very important to have somebody that's trained and able to reproduce these studies in a statistically valuable format.
What about the patient who is fearful of having an EMG?
I really think it depends on the examiner. Just like if you were going to have an IV placed in or blood drawn, the person doing it can make it a pleasant experience or can make it a horrible experience. I've done 14,000 of these studies. I'm also trained in interventional pain management, so I'm very well adept at using needles, and I've developed what I call a painless technique. And really what it is a way of relating to the patient and reducing their anxiety, and the actual pain from the needle becomes inconsequential, because it's really the anxiety that you have to overcome and gaining the patient's trust. Billing, on the other hand, again, you don't need prior authorization. Medicare, you don't. With third-party carriers, essentially what happens, you call them to get a prior authorization for the EMG, and they'll always say no prior authorization needed. But with that said, at the same time, I always recommend to my clients to still go ahead and go through the phone call prior authorization procedure. It's just always good to do, always good to have that noted in the chart somewhere that prior authorization was called for, and they were told that no authorization is needed. EMG NCV is still one of the highest paying diagnostic studies out there, especially when you consider what an investment it is for an MRI scanner, for instance. Buying the scanner and the maintenance contract, which can be as much as $20,000 a month, having a technologist, having to feed that scanner month in and month out, the overhead's very high. If you take that into account, the actual profits from EMG nerve conduction studies were much higher.